welcome. I'm thrilled to be here. These are the right people to have in the room for today. We talk a lot about innovation in healthcare, whether that's new technologies, new treatments, new approaches to care. But we're going to examine a more fundamental topic right now in this session, which is sort of the everyday interactions that take place within our healthcare system, including those between patients, providers, administrators, caregivers, and the impact on how those interactions make us feel, how we experience our health and our health outcomes. For many of us, the difference between accessing care or not is not just about cost or, do we have the right provider? It is about how it makes us feel. Are we respected? Do we feel safe? Are we understood during what for many of us, or for the people we're caring for, are some of the most vulnerable moments of their life? I'm Katie Drasser, as Lindsay said, CEO of Rock Health, and I'm honored to moderate this conversation, Does Better Health Start with Dignity? So dignity is not just abstract. We're here to answer a deeper question. How is health dignity a driver of better health? We're joined by three senior health leaders who these are like some of the best leaders in healthcare right here. So what a delight for me to join them. They're working at the intersection of care delivery, design, and communication. They'll share what health dignity looks like in practice, where it breaks down, what is needed from the industry as a whole to ensure that it's embedded in every touch point of the patient journey. So let's start by meeting them. Over to you, Ivor, Dr. Horn.
I am Ivor Horn, and I'm a pediatrician and health services researcher by training. I have spent my career focused on how we can improve the patient experience. I've worked at the intersection of health and technology and communication for pretty much my entire career. I now serve on the board of Boston Children's Hospital, where I do that work at that level. I've been at startups such as Accolade, where we focused on patient engagement, and I've served at large technology companies like Google, where I was a chief health equity officer. My favorite space is to do the work with the community and with others, engaging around how we can improve the patient care experience, and not just when you're in the four walls of a healthcare system, but the way people experience health throughout their patient journey. So that's me.
Jaime.
Thank you, Katie. Hi, I'm Jaime Wesolowski. I am a frustrated hospital CEO. I started as a hospital CEO back in the late 80s. I know many of you weren't around back in the late 80s. The last 12 years of doing all that was the CEO of Methodist healthcare system in South Texas, Central South Texas. And I spent my time focusing on providing the best hospitals. But it wasn't until I got to this job as CEO of Methodist Healthcare Ministries that I realized that I was leading sick care instead of health care. And I was very proud of doing all the things I could to provide access to quality health care and provide the highest quality health care in my hospitals. And that is very important, but I didn't realize until recently that that's, according to Robert Wood Johnson, only 20% of the whole, addition, basically, of what healthcare really is. And so we got to dig much deeper at Methodist Healthcare Ministries into social determinants of health, non-medical drivers of health. And I think one thing that we did that made us good was truly learn how to listen, and to listen to our patients and to listen to our communities. So I'll stop with that and go on to Jewel.
And I'm Jewel Jones. I'm a practice leader at Real Chemistry, where my work focuses on addressing barriers to better health and also broadening the aperture of who sees themselves reflected and benefiting from health innovation. I'm also the lead on our Health Dignity Initiative, which we're launching over the course of the next few weeks to include here at South by, which we've kind of become obsessed with answering the question with both data and storytelling. what does dignity feel like in healthcare experiences and health outcomes? Because we believe that in the next 10 years, it's going to be critical. It's going to be a critical component to improving the patient journey for more people. So the work that we're doing is always about how are we identifying those barriers to better health? What does it look like to create more mirrors so that more people see themselves reflected? Because we know that patients disengage when they don't feel seen, heard, taken seriously, and they don't believe that care or health experiences are reflective of their lived experiences. And so that's a big part of what it is that we do within the health equity practice, and also what we're exploring and solving for through the Health Dignity Initiative. And we've actually brought a little bit of a video because, Katie mentioned this, but health dignity isn't this abstract thing. It's actually a very tangible something that I was talking to someone in the healthcare industry last week who said, it's kind of been like this low hum that we haven't named. And in order to solve for something, we first have to name it. And so that's why we've really entered into this discovery of exploring what does health dignity mean, and then how do we design around it to ensure that we're improving health experiences. But to get us to that point, so that we're all in it together about what this looks like, how it feels, we actually have a little video to show.
See here. Right, we got your labs back. Overall, they look good, but I do want to talk to you about your iron levels. Just a few questions, okay, Natasha? Natasha?
Oh, I'm sorry, can you repeat that?
Of course. I was just going over your blood test results.
Right. I'm sorry, go ahead.
Well, your iron's a little low. Any changes to your diet or your menstrual cycle?
Not really. My diet has always been pretty healthy. My periods are more spaced out than usual, like once every other month recently.
Oh. Okay. Well, here's a list of some iron-rich foods, and I'll also prescribe an iron supplement.
Okay, sure. So what about my hair and the pain in my knees? I'm exhausted like all the time. I can barely make it through the day at work.
Your hair?
It's thinning.
Right. Sorry. Your hair, the joint pain, the fatigue, all those could be symptoms of perimenopause. I wouldn't worry too much.
I don't know if I can keep this up.
Well, the iron supplement should help with the fatigue. For the knee pain, you can take ibuprofen, or if there's any swelling, you can ice it.
But what if it's not just perimenopause? Can't we do some more tests?
Let's just wait and see how it goes. One step at a time, okay? I promise, all these symptoms are common for a woman your age. We'll explore other treatment options during your next visit, okay?
Right. Got it.
So just to pause for a minute, what resonated with each of you as you watched that? What are you taking away, Ivor?
Yeah. There's so many things that this brings up, but the thing that resonates the most with me are the things that were unsaid. And unsaid out of fear, unsaid out of being pressured in a rush, and sort of uncertainty. Those things really stand out to me. And I'll give an example of when I was a physician. And this was really the reason that I came into this became my work, and it is my work and why I do what I do. Because as a pediatrician, I would come in and I'd have a conversation with a mom or a dad, and I'd come out and speak to my colleague about the same patient, and there was a whole different perspective. You know, oh, they're difficult, you know, they're asking so many questions, or they're just not listening to me. And I was getting a whole different conversation with the parent, and I realized that there was this disconnect of something that wasn't happening in that moment. And it wasn't just impacting how people felt about the clinic or their experience, it was impacting their care. Because they weren't comfortable asking the questions that they wanted to ask. And they were afraid in that moment. And we as providers didn't necessarily have the tools of what to do. And we had our own pressures at the same time that we were navigating in the things that we were dealing with in the moment. Whether it was, did my kids get to school on time because I'm in clinic now? Or did I do that lab for that last patient? Those things that lead to distractions. And I think we don't recognize that and we don't connect those things to dignity. But they're those little things that add up to a person feeling seen and feeling heard.
First of all, this video was very well done. I mean, I think it probably strikes a nerve with all of us. We've all been in that situation, right, in a doctor's office. And one thing we try to do is train all of our people, all of our team members to lead by listening. And that's whether we are treating patients. Two of the main things we do is, one is we provide clinical care, medical, dental, behavioral health for the truly uninsured. So those are people that don't have Medicaid, no Medicare, no commercial insurance. We have no competition. You know, nobody wants to steal our market share. We do that for South Texas, and we're blessed to be able to do that. And the second thing we do is we work in community, and we go out and truly listen to community. So in both cases, we've learned how to listen very well. And it's important to allow those that are speaking to us to truly be heard. And one thing that we do is we have a tool that we call the Prepare tool. And we didn't invent it, but some of you may use it. But it's really kind of getting to the social determinants of health of our patients. So when they leave the doctor's office, what are they going home to? What are the barriers that they face? Everybody's different, right? What are the barriers they face at home? One program that we created from that is medical legal partnership. We start hiring doctors and paralegals because we found out that a lot of our patients, our doctors would say, I do everything I can for this patient, but they're going home and they're not sure if they're going to have a home. You know, they're not sure if they're going to be evicted or whatever else. So we start representing our patients legally. And so preparing for this conversation gave me an idea, and I was telling Jewel earlier, is like, what if when we ask our patients to fill out their Prepare tool, we ask a few questions surrounding dignity. What does dignity look like to them? Because it's going to be different for every patient and every community. And then let our providers look at that before they see that patient next time and adjust how they treat that patient. What's important to them? How do I treat that patient? And that would probably go a long way to better care for that patient.
Yeah, well, of course I love that idea. I was like, I'm in. Can we talk about this? That would be great. You know, as we were working on this this dignity initiative and really digging into the data, first I want to set a little bit of context that we looked at over 200 million digital data sources in the U.S. from a social listening perspective, and then surveyed over 300 patients, providers, and caregivers to answer that question, what does dignity feel like in health experiences and outcomes? And as someone whose background, I started my career on the public health behavior change communication side, of health, we really wanted to make sure that even in this video piece that we didn't put the onus on the patient. The patient isn't the villain. The HCP, the doctor is not the villain, right? They're navigating sides of a system and an experience that create constraints, right? And so how do we solve for dignity even in those small moments? And we call them moments of misconnect. And so in our research, and you kind of see it reflected in the video and even throughout this conversation, we found that there are 4 health dignity signals that we can really solve for and see and design around to improve the patient journey, care experiences, how we communicate to make sure that people feel seen, heard, and respected. And the 4 signals are the health dignity golden rule. It's not about treating people the way you want to be treated. It's about treating them the way that they want to be treated. So flipping what we've learned since kindergarten, a little bit before, hopefully some of us, on its head, right? The second one is that it's about a lot of little things. It's those moments. And Dr. Ivor, you talked about that a little bit. It really, dignity exists. It's this universal truth, but it's hyper individual to the care experience, and we see it across a number of different ways in which we've looked at the data. The 4th is safety is foundational. Safety is often a proxy. Dignity is also, safety, is a proxy for dignity in care experiences and conversations. And we saw in both the patient and the provider, right, in that video, that they both didn't feel safe saying everything that was coming to mind for them, right? But if they had, how might that have transformed the experience, the care experience, the conversation, and outcomes? And the 4th dignity signal is the provider constraints. I feel like in that piece that we all just saw, there was actually a 4th actor, and it was the time, it was the clock, right? It was time as maybe a little bit of a villain, but certainly a character, and that shapes the dynamic and also shapes the perception of the experience, both from the provider perspective and from the patient perspective. And so again, how do we solve for dignity in those moments too? And that's something that we're really exploring.
Jewel's the brainchild behind all this.
Yes.
It's just such brilliant work and so needed. So maybe we don't celebrate enough. So I want to touch on how this personally impacts you, but will you say the 4 again, just really, so we're holding those through this
The health dignity golden rule, number 1, a lot of little things. It's a very technical term. The 4th is safety is foundational. And the 4th is the provider constraints and how the constraints erode the experience or the perception of experience for both provider and patient.
It's so helpful to hold that frame as we come at it from different angles. For a quick personal angle, Jaime, I want to start with you. Do you have a sort of defining moment of health dignity in your life that you carry with you through this in your personal life? Like it's sort of that it stands out to you or it stays with you, where you remember how it made you feel, for better or for worse, you know?
Yes. So I faced stage 4 throat cancer a while ago. I was diagnosed in 2006 and got radical neck surgery, radiation, infusions, all of the above to try to survive that. And as I was going through my radiation every day, I had to get a couple injections before that, and then wait 30 minutes. So I waited with my nurse, and she was the great example of listening to patients, I think. And so she got to know me, and she found out what was important to me, and that was prayer. And so for some portion of that 30 minutes, every single day before my radiation, we prayed together. And that meant everything to me. And I'm sure she didn't pray with every patient. I think she took the time to understand what was important to every patient. And since she had that time, she used it wisely. But that was an example of someone that found out about me, what was important, especially when you're facing possible death. You know, there was no guarantee I was going to get through that. And a lot was on your mind. So prayer was more important than anything right then. But that's the thing that sticks with me personally, as really understanding my dignity as a patient.
sort of goes to that golden rule. Maybe
Yeah.
not for everybody but for
Yeah.
you and that provider seeing that. I don't know, Jewel, if there's a moment for you.
Absolutely. There are a lot of little moments, right? But for me, the one that stands out the most is actually my journey to motherhood. My first son was a 27-weeker, so born very prematurely. Don't worry, he now says he wants to be a neurosurgeon or a pilot, depending on the day. But as you might imagine, my husband and I spent a lot of time in and out of the hospital, and we all know the data around maternal health in the U.S., especially for Black women. And I happened to have a person who I knew fairly well on my care team at a level 4 NICU, but that helped us to navigate the experience. But more than anything, the thing that stuck out to me as someone who, as I was recovering, went to the hospital that was about 20 minutes away from my home every day for 68 days to sit by my son's bedside as isolate, it was the parking garage attendants who learned my name. Who were my first stop to, as I would catch my breath before getting out of an Uber because I could not drive myself, or someone was driving me to the hospital with a bag that weighed more than 20 pounds, right, every single day. It was the parking lot attendants who remembered my name and who made sure I had VIP service when I pulled up. And it would be funny because my husband would say, they don't remember me. But that experience gave me confidence to then engage in a different way with those who were the healthcare workers within the NICU, with the neonatologist, and it helped to build my confidence walking into that space every day, that I knew I was receiving the best care, in part because even the parking lot attendants were incredibly hospitable, generous, and thought about care personalization for those who are navigating really difficult moments.
Not totally where you think it might happen, right? Like that might not show up in a classroom of like, where can we make the experience better? Ivor, what about for you?
Yeah, I have to say this has been a journey for me. This started when I was 9 years old. My dad had a traumatic brain injury and developed a seizure disorder. And the first time I went into the hospital and saw my dad vulnerable, my dad was getting a spinal tap. My mom had finally let me come to the hospital, and I looked around. I was standing at the door, and my dad, who was this very quiet man, my dad never raised his voice. All I could see was these people standing around him. He was getting a spinal tap. And the doctor and the nurses telling my dad, like, Mr. Braden, you need to be still. You need to stop moving. And my dad yelling, like, you let me go and I'll show you how I can move. And I was like, whoa. And my mom walked into the room. She called my dad by his nickname. And she said, Dub, you need to be still so they can do this. My dad immediately paused and stopped. And everyone in that room paused and stopped because she commanded the room, and she didn't raise her voice. She was just firm. And she taught me the importance of speaking up and not necessarily being loud in a healthcare environment to command dignity and respect for yourself and for your family members. And so that became a journey for us. We were in and out of the hospital for my entire childhood. And the thing that I remember the most was I did not want other families to feel the way that my family felt and had been treated during that experience. So I went into healthcare with the purpose of disrupting healthcare, to say this is not the way it should be. And my dad had a neurologist, Dr. Rose, because my dad was at the VA. We didn't have insurance. And she was the most wonderful physician. She walked through my medical career. When the time came, she sent me my dad's medical records so that I could review them. She kept me abreast. When my mom had a visit, they would call me. I would get the download, Dr. Rose and I would come up with a plan. When he shifted to another physician, that physician was not taking my call. She said, hold on a minute, let me take care of that. And she called them, made it clear to them, you need to work through the care plan with her. And she taught me how to be respectful and care for a family and move through that journey. And this was over 30, 40 years of time that she walked with me through the care of my dad. And for me, that learning and that understanding and the appreciation of dignity and respect, and for me at the time, I didn't have dignity as a word, it was really about respect. That for me, that stuck with me. And so for me, it's been a journey. It's not just one thing,
Right.
It's all those little things through the journey.
Well, and you became, somebody, you're on both sides of that video in your journey. And I think, when we hear this stuff, I bet everybody in this room is like, well, yeah, why wouldn't we do any of these? It seems so obvious when you say it out loud. But from where you sit, where does it start to break down? Like, why isn't it? Why doesn't it happen more often? Why don't we hold that frame? What are the breakdowns? What are those?
The breakdown happens even before a person gets into the room. It happens before the physician gets into the room. It happens in the fact that, and a patient's journey and a person's journey in healthcare happens when they talk to their cousin or their grandma, or the thing that they learned in their family that's just the way it is, or something that they read online, and and even more so now, the thing that they read online and they looked up online that they now have questions about, but they have that fear of bringing up that question and that conversation once they get in front of the caregiver. And then on the caregiver side, that urgency, being in a rush, all of the other things that I'm thinking about in my head leads me to not pause and take a moment to listen to that question. And sometimes it may be misinformation or disinformation, or it may, for the physician or the caregiver, be something that you just don't really know yourself. And you've got to have the humility to say, you know what? I don't know about that. Let me look that up. And let's work through this together. And I think all of those moments before, during, and after, when you go home and think about it and say, these things didn't happen for me, and you bring that into the next visit. Mm-hmm. And so it starts before you walk in the door and even after you're gone.
And then it's like reinforcing patterns. You go into, you like, you pull into the parking lot, you're like, I know there's gonna be a bad experience. You like already are anticipating it because that's been your experience.
Yeah.
From a health system perspective, I mean, you have to think about this at a few levels, but in your mind, where's this breaking down?
Yeah, I think from a health system perspective, I'll start with that, and then I'll go into public health and health equity real quick. But from a health system perspective, I'm a big process person. So as a leader of a health system, I think it breaks down from the top. I think that we, as leaders, have to own it. And what does that mean? That means planning for it. That means putting processes in place where you don't let it break down, but you look for opportunities to receive dignity and listen and things like that. And I think it's the same way when I make that shift from running hospitals and hospital systems to focusing on public health and health equity. It's the same thing. It's really putting the processes into place that we go out and not assume that we know what's best for a community, because when you see one community, you've seen one community, and you have to truly listen to all the people that make up that community to find out what's really important to them. And you can't assume anything. I really think the same thing is true patient by patient. When you're doing more downstream care, you can't assume anything. That's why it's so important to put the processes into place, to truly listen, to receive, again, like I said at the beginning, lead by listening.
I want to add that because I do wear many hats.
You do. If there's a hat, Ivor hat. Yeah. Mm-hmm.
As a board member of a hospital system, of a children's hospital, and I've been a medical student, a resident, then an attending, and now, and faculty, and then sitting on the board of a children's hospital. It is really important and part of my responsibility as a board member for accountability. How do I hold leadership accountable because when you say it starts at the top, it starts at the top with the executives and the CEO, but it's at the board level as well. And that is our responsibility as a board to hold a leadership team and for them to hold them accountable to make sure that we're improving on and that we're treating people with dignity and respect.
I can see you bringing your mom's energy into that boardroom, which is great. But Joel, for you, you did the social listening 2 minutes. Where would you diagnose the breakdown?
Well, I agree with both. I think that one of the insights, or one of the data points we found in our research was that 71% of people who we surveyed, patients, providers, and caregivers, have had a dignity-defining moment at some point in their care experience. And one of the things that I know we talk a lot about AI, but with the urgency of AI, making sure that people can find trustworthy, evidence-based information online that they see themselves in, so we're creating more mirrors so that people see themselves. I think that there's a lot of urgency behind that too, because it's going to be even more critical as people rely even more on AI-driven apps to find and answer health questions. And if they're not feeling heard, if they're feeling dismissed, care is breaking down, as you said, before they even walk into an appointment. And so the role of communications, the role of ensuring that people are able to find evidence-based health information that they feel like they can trust and that they see themselves in is going to continue to be critical, and maybe even more critical.
Sometimes this comes down to resources. I don't know if when you were watching the video, the constraints that were showing up everywhere, whether it was knowledge, time, just all the, constraints. So when it comes to resources, how do we make sure the whole concept of dignity happens? What does that look like when it comes to, tightening budgets and other sorts of constraints that are playing out in the system? Any of you, please start. Maybe Jaime, you actually probably look at the budgets in your board role.
Well, I think when you get to resources, as a leader, you could always argue that resources are constrained, that you just never have enough, right? Leaders can do that, CEOs can do that. But I really think it's all about reframing how you think about the resources and reallocating those resources, and focus with starting with the patient and not starting with you as an organization or you as a provider. And I think that's really important. The example I go back to was when I first got to Methodist Healthcare Ministries, we had a terrible problem of patient no-shows. I mean, much more so than I ever saw on the hospital side with our physician practices, and some of which we owned. Just never saw that. And I said, gosh, we have to do something about it. So my initial thought was, well, somehow we have to penalize our patients for not showing up. But that was really, really wrong. What we did as we really got together and talked about it is we need to find out what's the root cause of the reason they're missing the appointments. And that is so that's reallocating your resources, taking a little bit of time to fully understand what is the issue. Our patients are more vulnerable, I would argue, than the average patient. And when they miss an appointment, there's really a reason they miss an appointment. It's not because they didn't feel like going to the doctor that day. So it might be transportation. It could be a multitude of things that we have found. And then so we got to find out what the reasons are, and what do we do to mitigate that? A lot of it is really just meeting the patients where they are, finding out how we address that. And so we did that and made sure that no-show rate went down dramatically by finding out what the real causes are and trying to mitigate that. A lot of it was just doing virtual healthcare. Sometimes that is sufficient. It's not sufficient all the time, right? But sometimes that is a lot better than not seeing the patient at all. But we did a lot of different things, and that was really just kind of backing up, finding out the root cause, and not blaming the patient.
Yeah, I have a patient story for that. When I was seeing patients in a clinic in the community in Washington, D.C., and we had residents in our clinic. And one day, one of my moms was very late, very, very late, and the resident came to me. And they finally came. They were maybe an hour or so late. Mom came. She had 2 out of her 3 kids in tow. And the resident was like, "We're not going to see them. They're late." I just paused, gathered myself. I said, that mom had to take 3 buses, pick up her kids from school, to get here for this appointment. We will see her today. And I think it is the importance of putting care in context that we often forget, because we focus on that what I used to be 15 minutes of fame, 7 minutes with the provider, however it is each year. But without the context of the world in which our patients live and the experiences that they have that you brought up, Jaime, we are failing them, and we fail to give them dignity when we do not respect the complexity of their lives.
That's right.
You mentioned context. The first thing I think about with relation to your question about resources is some work that we did during COVID with an organization called the Black Coalition Against COVID. Now, I don't know who was for COVID, but they were definitely against it. And an amazing organization made up of people who have been in healthcare for a long time, community serving organizations, and leaders that kind of stretch across a number of different ecosystems. And one of the things that we saw at the time through the data were that, of course, there's a lot of disinformation, especially going toward the Black community in the US. And we saw this gap in trustworthy voices in the national narrative, able to really kind of reach and engage populations in a way that could make a difference in their health and their health outcomes. And we helped them to launch a campaign called A Love Letter to Black America from America's Black Doctors and Nurses. And when I think back on that time, it really was about dignity. It was about putting care in context and making sure that people saw themselves reflected and their values reflected, and they saw themselves being seen, heard, and taken seriously. And so this open letter, this love letter that was signed by presidents of the 4 HBCU medical schools, the president of the National Medical Association, the National Black Nurses Association, it really was like a United Nations almost of organizations. And it was about putting care in context and from the lens of communications. And I think that the work that we do today, it reflects those same values, right? How do we, again, make sure that people feel seen and heard? But one of the things that I admire most about the Black Coalition Against COVID and the organizations that made it up is that there were a number of community serving organizations, and one of the leaders said, we're used to making brick without straw. And in many ways, when we are resource strapped, we have to get creative, right? We have to get creative about this can't be a barrier to us reaching and engaging the audiences that we need to reach, or ensure that we deliver the best care possible. And I think that there are a lot of learnings, especially if you partner at the community level and you support community serving organizations and help to fund them, where you find small I innovation. To what can sometimes be seen as these resource constraint questions that we battle with at a broader level from a scale perspective.
Absolutely. I'm almost thinking about your golden rule of resources defined by whom. In my role at Rock Health, I work with a lot of tech entrepreneurs, and I can picture being in a room with a tech entrepreneur speaking to a room of physicians saying, this new thing's gonna save you time. And in their head, we could make a video, they say, my time's not my time. Jaime's in charge of my time. I'm gonna have to see more patients quicker. So it's like resources defined by whom?
That's right.
And all of you play some role in the tech world. Tech is, everywhere in healthcare right now. I wanna shift to that for a minute of how do we bring this frame to that tech lens? How does tech bring this frame to those innovations? Where do you see this showing up? I mean, you were head of health equity at Google. It strikes me that you may have a thing or two to say about this, but how do we really ensure that all this innovation promotes dignity rather than erodes it? I mean, there's an upside via tech we could have, but how do we make sure that tech's not eroding this?
Yeah, and I think there are a couple of things. Well, there are a few things that I could say, and we could go on and on about this. I think there is a lot of information available to people, and we know that there is misinformation and disinformation, and distortion of information, and our perspective of who is susceptible to that information, to me, is very narrow compared to the broadness of people who are impacted by information. And I think our task in the healthcare setting is to recognize and be willing to listen and answer questions in a respectful way with dignity, so that people are informed, so that we're not pushing people off and making this expectation like, oh, how could you not know that? But with dignity and respect, having a conversation and being responsive and answering people's questions. So there's that first piece of information and misinformation. But I also want to talk about, I want to start at a positive frame of ways that technology has been and can be helpful in the environment. One of the things that you saw in that video was the physician at the keyboard, and we all felt and saw the disconnects that we had when our physician or caregiver or the nurse or the front office person was just talking and not looking at us and asking us a series of questions. Now, with ambient listening, that's shifted to where the physician isn't necessarily doing all that typing. They actually have the opportunity to make eye contact, to have a conversation with you, and work on those things later. I think that is really an important opportunity. To be clear, back to trust. To have that listening device in the room requires trust, and there is a general fear of how information will be used for or to target people in this environment. And I think from that physician relationship, it is important to know, like, this is your opportunity to really build trust and connection with a patient leveraging this tool. I think the other thing, and for me, I get to like go from the place of the physicians using the tool and implementing the tool to the back, all the way back to the process of building the technology. And working with entrepreneurs and working with large and small tech to build tools. And there are a few things that I think are really important. One is building with, not just for, and building with communities that have been historically marginalized and have many, many legitimate reasons to distrust systems. The opportunity to build with and in context, I think, is really an important opportunity. Someone asked me recently if I had $1 billion, what would I do with it? And I said I would build a coalition of people from diverse multidisciplinary backgrounds and put them together with communities and build solutions and build AI tools for those individual communities. So if anybody's listening, but I think that process really fundamentally comes to respecting communities as the authority figure on their health and their health in context for them. So that to me is very much a part of dignity and respect. And then the next thing for me, and this is for health systems, is in that process of building with community, you know, we're integrating technology for clinical workflows, but what about the patient workflow and the patient experience? How are we incorporating that as part of the process? And so for me, technology goes from how people use technology in their home as consumers before they even get to you, because we're talking about the journey, to how the technology is being built and who it's being built with, and how it's being implemented and evaluated when it's implemented in a system. So, yeah.
Your point on trust is spot on when it comes to technology, AI, because really when you think about AI, unless you do something different, you're trusting whoever developed the algorithm, right? Mm-hmm. And so when it comes to what we do, again, I caution everybody to take a step back and to make sure the algorithm is what you need it to be, that you put the human touch into the algorithm, that you make sure you're using AI to get the most out of it, and to then make sure that dignity is there. Mm-hmm. So again, it's something that you can't rush. It's something like, it's just like public health. When I went from medicine to public health, I realized that it took a lot more planning. You got to slow down. Because once you start, you don't want to stop. Public health is not something you want to, pump the brakes on all the time. You can do that a little bit more in medicine. Try something, learn from it, alter it. Public health, you got to stay with it once you make that decision. So it's the same way. So anyway, I can't say it any better than you did, but I think it's really the trust and slow down early on and make sure that you're using technology to take full advantage of it, because it can be fantastic. But don't assume that it's there that's for what you need it for.
Yeah, it's a tool.
It's a tool. Yeah.
It's a tool.
Yeah, so one of the things that I found most fascinating as we were digging into this health dignity data, and this wasn't our research, this is secondary research, but we found this study that noted only 40% of physicians in the U.S. Trust that their patients know how to find evidence-based health information online. And I think about that a lot, especially as we consider even my own personal use of AI tools like Claude or ChatGPT or others. And Ivor, when you and I were talking a couple of weeks ago, she taught me this term. I want you to talk about this for a second, because I think there's something that's really wonderful about AI and innovation in making health information accessible, as long as you know how to navigate, right, finding trustworthy information. But one of the big questions is, are people ready to receive the most helpful information that AI can share with them or provide to them? And you had this term that I've shared with so many other people. You called it brutal mode. Do you remember?
And I'm sitting here going, what term did I use?
Because I mentioned to her that the tools that I use, I say, like, don't give me happy talk. I don't want happy talk. And can you talk a little bit about the term brutal mode and like how it returns insights that are more straightforward?
Yes. So the danger for me of
What's the term? Say the term.
brutal mode, like you're brutal.
I thought you were saying Roomba.
No,
no.
brutal.
Brutal.
Okay,
brutal.
we're in brutal mode.
So
Yeah.
brutal.
Okay.
So brutal mode. So first, I'm going to give the opposite of brutal mode. Algorithms are designed for you as a consumer to continue to use them, right? Their goal is to get you to use it more. So they say things in a pleasant way. Your response is in a pleasant way. The response is designed to get you to ask more questions, to engage more, to want to utilize the tool more. I am in the process of writing a book, and the thing that I found for me is that when I ask people for feedback, everyone wants to be really nice. And I'm a researcher, and I had many mentors who redlined my grant applications in a very significant way, and I began to take those as good feedback to improve myself. And so as I was working on writing my book, I said I have a writing group, and I said to one of the people who've written a book, I was like, hey, I want to get feedback, but I need to do this, and everyone's so nice. And she said, oh, I just use Claude in brutal mode. And so when I write and when I want to get feedback on something, I say, Claude, be brutal. and tell me these things. And what I found was so amazing was what would have taken me 6 months to a year in critical feedback to get from an individual who didn't want to hurt my feelings. Claude gave me the things that I needed to hear and the ways to improve. And so personally, now I call him Claude Brute. But it has been very valuable. And you have to realize that this is a large language model. Like math is math. It's doing a calculation on what's the next word that it should say and how it should say it. And so you have to put anything that you say, anything that you ask in context. But people do not know that necessarily, and people do not understand when they are asking questions, they're getting something that makes them feel a certain way. They're feeling a sense of dignity and respect in the response that they get because of what they are asking and the way the tool is designed. And we have to recognize that they are coming into us with questions with that lens as part of their experience. So we have to be respectful. You can't run and be Claude Brute to a person who's just had a wonderful experience with Claude in a different tone. So I think it is important for us to recognize that.
It made that conversation stuck with me because it's made me really think about, like, how do we deliver health information in a way that people feel seen, heard, and respected, but it's clear enough, respectful, but maybe a little bit more brutal mode, right? To get them where they need in their journey as a patient, because the nice isn't always what's best, right? And so how can we frame things? How can we think about things, designing for dignity, but also in a way that still gets them with
we often say, you can be nice and you can be kind.
That's right.
And being nice is not always a good thing because you're not telling people what they need to hear. And you can tell people hard things and still be kind.
That's right.
And I think as a physician, like, that is really an important part. And it's hard when you're constrained on time.
That's right. Some of what I'm thinking about here too is when you put the dignity lens on this and you think about tech and you think about trust and context and tech as a tool, we know from our data at Rock Health, they don't say this, we're not measuring this, but they're actually seeking dignity. So where we see the demand is where people feel seen, where they feel, tech can be a tool for that. If you can find a provider that you feel like sees you more, maybe has some shared experiences with you, via telehealth, via chat, what have you, like that there's a demand for dignity that tech can enable or facilitate with a bit more ease or a bit more affordably in a perfect world. It can go wrong, but I'm excited for you to keep building this work and kind of like support all of us, and we're on the journey with you, and sort of like how we can hold some of these things in our designs, in our data, in our builds, in our leadership. Jewel, for you, with that in mind, how can everyone in this room sort of champion health dignity to help improve health experience, health outcomes? Surely there are things every single one of us can be doing.
Yeah, I think one of the biggest things is not seeing this as just kind of a moral lens, but really seeing dignity as a behavior that we can design around to improve the patient journey, to improve the experience, and ultimately to improve health outcomes.
Yeah. From where you sit.
For me, it starts with listening. Listening to hear, not to respond. The basic things that we need to do, listening to hear, not to respond.
Yeah, and not to sound like a broken record, but let the patient dictate what dignity is. Truly listen to them.
With that, thank you all for being here. I hope you all are as excited as we are for Jewel and the Real Chemistry team to launch this initiative with partners, and this work is really important, and I'm very grateful to all three of you for your leadership in this space. We talked yesterday on this stage about trust in tech, and while you may not trust an institution, the data shows surely leaders like you are really, really important for this sort of next wave of innovation and more dignified care and innovation. So thank you. Thank you three so much for being here. Thank you all for being here.
Thank you.